And welcome to tonight's treatment planning webinar. Thank you for joining us. This is a special occasion for us as we have three members of an interdisciplinary panel, all from Chicago, Illinois, or the Chicago area. Dr. Alan Rosenfeld is periodontist. We've got Brian Vence, who's a restorative dentist. We've got Scott Benkover, who is an endodontist. Now, we all have this difficulty of determining whether we should extract teeth or not, and what's the best course of action for a patient. You know, when we think about it in an older individual, well, you know, we kind of know what we can do and how we can treat periodontally and what we can do restoratively. But when it comes to a person who's been involved in major trauma, then there are other considerations. And really one of the questions is, what is the patient's capability of healing? And how aggressive should we be in determining what we should do? And furthermore, how do we present those options to a patient who's very emotionally involved, emotionally charged, with parents who are also emotionally involved? How do we do that? All of us have encountered this situation in some way in the past. What you're going to see tonight is a case of interdisciplinary care which included the patient. So the patient was involved in the decision, included three top flight dentists who were able to help this patient move forward. So if you have questions, you can go to the bottom of your screen. You'll see a Q&A panel. Just type your question in there. At an appropriate time, I'll be able to ask the question of our three panelists. If you take a look and you don't like the position of my face right now or anybody's face right now, if you just take your cursor and go to the middle of that screen, you'll be able to left click on it and drag that thumbnail sketch wherever you want. Okay, and so with that, I'd introduce to you Dr. Alan Rosenfeld, Dr. Scott Benkover, and Dr. Brian Vence. Alan, take it away.
Thank you very much, Lee, and thank you for the opportunity to present this webinar. What we're going to talk about this evening is interdisciplinary information management. And what's significant about that is putting together a team to help develop a treatment plan for patients. But often what happens is that there's a need for co-discovery because oftentimes patients don't understand the capabilities or what we're capable of achieving. And so we'll talk about this co-discovery aspect in depth. The names that appear on the screen are actually all the people that contributed both therapeutically as well as information resources for us. And I kind of spearheaded this interdisciplinary quest in an effort to help this patient. So the learning objectives for tonight is to talk about the power of co-discovery, to understand the patient's problems, and to get them to accept responsibility in helping us understand the risks and benefits of treatment. It's also an opportunity to create a level playing field so that we can establish creative synergy and avoid personality-driven dominance, which often limits accountability and open discussion. In addition, we'll talk about the role of the periodontist in management of the periodontium. And I think it's important to understand that the periodontium is that genetic unit, if you will, that gives us unique opportunities to manage the dental alveolar complex. We'll also talk about treatment uncertainty, and this case certainly is one which underscores that. And the possibility that future breakthrough or discoveries which aren't available now could be a part of a patient's future as long as we don't overplay our hand in overly aggressive treatment. So let's begin with the initial examination. This patient is Amanda, and this is the way that I examined or saw Amanda on November 5th of 2012. It was about 2 or 3 days after she sustained an accident where she basically did a face plant riding with her husband on a bicycle and caused this damage that you see here. Just a different view. We can see fundamentally a rather healthy, tooth and dental gingival complex, but we can see the trauma that's occurred in the anterior segment of this patient's mouth. Just showing you additional views. With the fracture of the teeth, it's hard to really understand the level of displacement, but we can see the edematous nature of the gingiva on the palate, the avulsion of tooth number 11. And certainly this is a situation which has significantly traumatized this young patient. What's remarkable is the absence of extraoral facial trauma. We're looking at some abrasions, and it appears there may be some abrasions on her neck, as well. But oftentimes, at least my experience, in the presence of a GPR training program, oftentimes in the emergency room, the patients that had significant trauma, which excluded tissue trauma, often resulted in fractures. And we'll kind of explore this a little bit together. So the patient's past and recent dental history was essentially unremarkable: routine hygiene care, minimal restorative needs. There was recent extraoral and intraoral trauma resulting from the bicycle accident. But one of the key players here in this patient's management is the future dental patient, or I should say a fearful dental patient, exacerbated by the trauma. And I highlighted here PTSD because I think that helps everybody understand the level of involvement for this patient. Another significant factor is that the patient was under the care of a general dentist whom I had no professional relationship at all, which added a very difficult issue in terms of overall management. And it's important to understand that the restorative doctor referred this patient to an oral surgeon for extraction of maxillary anterior teeth in preparation for future dental implants. And she was referred to my office by her employer. So this gives you a brief summary of her dental history. So if we look at her medical history, she's a 25-year-old female in really good health. She does smoke, and her ASA classification is 1. So this is the panoramic radiograph that I received from the emergency room when I requested records. And you can see some evidence of the avulsion. You can see some evidence of a fracture here along this line here. But you'll see from additional documentation that this really doesn't properly dramatize the level of involvement from this radiograph. This is the summary note from the ER at the University of Illinois in Chicago. The good news is she was wearing a helmet. They describe a little bit about the accident, but she never lost consciousness, so neurologically she was very lucky and didn't sustain any problems there, no cervical injuries at all. So these are the radiographs that I took at the initial examination, and I think we have a little bit more clarity as to what's happening. We can see certainly the apical third fracture in this canine, the avulsion in the number 11 area, and assorted fractures, intrusion of number 10. So there's certainly a significant number of concerns that we see on these radiographs. But as we're all aware of today, CBCT, or three-dimensional radiography, is really an important component that needs to be part of the diagnosis. So when we look at the view on the left, which is the axial view, you begin to see teeth being displaced in various degrees of horizontal displacement. The panoramic view, at least this particular slice, shows the avulsion and some of the other situations that exist with each of the teeth. But the panoramic view can be a little bit confusing because we may be in a particular plane where part of the tooth is in the view and not in the view. So we really need to look at the totality in order to get an understanding. I think what's remarkable about the three-dimensional reconstruction here, in the absence of restorations, artifact, beam hardening, doesn't play a role, and we can begin to see the fractures that appear in a number of areas. And if we look at the three-dimensional X-ray here, we can see all of these fracture lines throughout the anterior premaxilla. And we can also see the extension of this fracture line into the posterior palatal aspect. So we can certainly imagine where the energy was distributed in the injury here, more to the maxillary arch rather than facial trauma. So when we begin to look at the cross-sectional views, and I've gone ahead and created the cross-sectional views for each of the teeth, we begin to see some interesting things. First, the canine number 6 seems to be a little bit labial displaced, as evidenced by the alveolus here and the fracture. We can see considerable displacement and fracture of number 7, along with the alveolar bone being retained, at least in this view, intact with the attachment to the tooth. I think it's important to observe the comminuted nature of the fractures, which are occurring here on the palate. When we look to number 8, we can see a more significant comminuted fracture where this bone is completely displaced palatally. We move to number 9, we see the continuation of injury that's present here. And this being the intruded tooth, we can see evidence of fractures in a number of areas. And then we move along to the canine, where largely there's a palatal fracture. And to me, remarkably, there appears to be at least labial bone intact. This little void here is probably an area of clot retraction. But fundamentally, we're looking at a dental-alveolar complex that has been significantly injured. So when we begin to look at a diagnosis, we're talking about facial trauma as well as intraoral trauma, fractured teeth with an apical fracture on number 6, comminuted alveolar fractures with tooth displacement, avulsion of number 11, and certainly uncertainty of the pulpal status of these teeth. And there was a loss of vitality with number 7, and it was actually symptomatic and was painful as part of the initial presentation. She has a class 1 skeletal pattern with a thick gingival phenotype. And according to the Mandelaris dental alveolar classification, and I might add that Brian Vence was a collaborator in this paper with George Mandelaris, she really has a thick dental alveolar complex. She doesn't have a lot of gingival display. And the modifying factors that we came to terms with is that she's a fearful and anxious patient, great uncertainty in terms of long-term prognosis, and there are financial risk benefits, which we'll talk about a little bit. So the treatment, let me digress just a moment before we talk about this treatment options, and let me tell you a little bit about the history of Amanda. I was leaving town to go visit some grandchildren, and on my cell phone before I was boarding the plane, I get a call from Amanda. And Amanda says, I'm on my way to the oral surgeon's office to have my teeth extracted to place dental implants. She felt that that was the best long-term financial opportunity for her, because if she was going to lose her teeth, she didn't want to spend time messing around with her teeth and really wanted to move on to the more definitive solution. So I said to Amanda, I said, you know, Amanda, we had a consultation. We met with you and your mother, and we talked about the fact that we needed to make some decisions. And other than the painful number 7, we had time to really assemble a group of people, as well as to do a literature search and to talk with other respected dental specialists to see what it is that we could actually do for you. I said, so Amanda, if you want to proceed with the oral surgeon and have teeth extracted, that's okay. I don't have a problem with it. But I will call you back in about 2.5 hours when I land at my destination, and you can tell me what your decision is. And then she asked me, well, if I have my teeth extracted, will you be able to do the implants for me? And I told her, no, I would dismiss myself and not become a part of her future treatment. So that was how this kind of evolved. And when I landed at my destination, I called Amanda back and I said, have you decided what you would like to do? She said, I'm going to continue to work with you. Let's spend a little time trying to figure out what's going on. So that led us to the opportunity to look at these 3 options, which is part of this co-discovery process where the patient is beginning to learn what options are available in dentistry and what the risks and benefits are of each. So one of the options was to extract the maxillary incisors with implant placement with a supported restoration to follow. The second was to attempt to save her teeth, but there was considerable uncertainty, but it would require an interdisciplinary approach. And of course, the third option, which was totally unthinkable to me and the patient, was the consideration of a removable partial denture, which would provide great liability in terms of soft tissue and dental alveolar stability for the future. And of course, the financial and emotional management was something that was ongoing because Amanda thought it was best to move on with the definitive financial investment as opposed to the possibility of having uncertainties associated with trying to save the teeth. So we'll kind of move through this. So our global perspective was to manage the acute injuries and improve aesthetics, consult with the patient, dentist, and oral surgeon, which I had a non-relationship with, obtain appropriate radiographs, and convene an interdisciplinary consultation to explore treatment options with the people who were listed in the original presentation slide. Help her with the symptomatic teeth to be treated endodontically, look at orthodontic therapy to consider repositioning, and eventually restore and replace the teeth pending response to treatment. So at this particular point, Dr. Vence is not even involved at all with the patient, and Dr. Benkover is about to become involved with the patient, and we'll see how this all plays out. Well, at this point, I'm actually kind of lost. This is not something typically that a periodontist would be involved in, but I knew that my role as a periodontist and the potential to save these teeth, to save the soft tissue, to manage the comminuted fractures to a point where we could get dental alveolar stability, I needed to look for sources. And so the International Association of Dental Traumatology had a guideline format, and I went and looked at this, and they had various schematics, and we dealt with root fractures and the alveolar fractures that you see on the left. And essentially the treatment was to reposition displaced components, okay. And then when we look at the favorability outcome here, about the most favorable that you could look for is to continue to evaluate the patient until the next appointment. And then in the unfavorable outcome, we're talking about the unfavorability of extrusion of the coronal segment for an intruded tooth, and then also the possibility of resorption. And I began to realize that this was not substantially different than what I learned about in dental school, and it really didn't give me a lot of confidence as to where we were headed in the future. But it was a starting point. And this really was the tipping point to be involved with more in-depth discussion with others. So the first attempt to improve the aesthetics occurred about a month from the time that I first examined her. And this is the restorative doctor's bonding of the anterior teeth. We can see that number 10 is still intruded, and the soft tissue healing for number 11 is pretty clear. So Scott began the endodontic consultation. I'll let Scott take over, and he'll kind of walk us through the endodontic consultation process.
Sure. Well, thank you, Alan. Even before meeting Amanda, Alan and I had a conversation on the phone, shared a few photos, reviewed the history, and I quickly brought Alan up to speed with what we see when we see trauma patients, in the sense that it isn't that uncommon to have comminuted fractures of the maxilla adjacent to a tooth that's been luxated or intruded or displaced. And the beauty of the healing of the body is that if we can stabilize the tooth, then these fractures heal. So initially, Alan was approaching me with the question, hey, can we actually save these teeth? Or are we looking at just extracting these remaining teeth? And I wasn't sure yet. I hadn't reviewed a lot of the information that Alan has thus brought to your view through this presentation. But through our discussions, I said, hey, this really should be a patient and a situation where we should try to save these teeth because we want to preserve the bone. If you go back in your mind to where Alan was showing the comminuted fractures over the entire anterior maxilla, and we saw that prior to even seeing Amanda, my thought was if we extract the teeth, we're going to lose all of that bone. And it's not uncommon to have a buccal-cortical plate or a palatal or lingual cortical plate be fractured along with the luxation. We stabilize the tooth, we get that to actually heal. So we were hopeful before seeing Amanda, but we really didn't know what we would find when we sat down to actually meet Amanda. I remember my first time walking into the room to meet Amanda, she was actually in tears. She still, the first words out of her mouth were, should I be trying to save my teeth? Not can I, but should I? And I kind of brought her to my thinking was, well, let's do some assessments. Let's do a thorough consultation. I'll give you my initial thoughts, but then we'll really want to discuss with the other specialists involved to come to a conclusion of should you. We will worry about can we and can you, but let's talk about should you in a few days after all of us have spoken. So I met Amanda. She was kind of emotionally fragile. She also was the type of patient who in general wasn't crazy about going to the dentist and sort of a nervous Nilly to begin with. So she had that with the post-traumatic stress of the incident on top of being a nervous Nilly. And she was a bit of a patient who we really had to pause and think, we've got to put our best patient treatment procedures in order for her to really make her feel comfortable. Whatever it took, we need to make this patient feel comfortable so she wouldn't lose faith in us. So during my consultation, I really wanted to first assess her medical history and her emotional status. I knew she was a little bit fragile, but as we got to know each other, she started to smile, the tears stopped, and we talked very professionally about what we saw in her radiographs and the CBCT. And then we did some clinical evaluations. She was pleasantly surprised in the clinical evaluations that we weren't hurting her. We were very gentle. And so it started to build some confidence with her. Then we started to discuss our findings from that day, both what we saw in the bone, again, trying to promote her thinking that just because we have a fracture in the bone doesn't mean it's hopeless, that bone heals. Tooth fractures don't. Yet we can do some things to promote healing even in the presence of a tooth fracture. We did our pulpal evaluations to establish the pulpal status of the teeth. And we discussed a lot of different types of outcomes as well as what could possibly happen in the future when it came to pulpal health. Because in a trauma, we find that we may come up with some initial diagnosis, some initial pulpal diagnosis, but very well following a trauma, a tooth that could have responded normally in our initial pulpal findings could then convert to a necrotic tooth, could then convert to having a periapical finding, could then actually have resorption as well. So we had to talk about these possible outcomes. Meanwhile, understanding that if we at least maintain these teeth, but yet maybe in the future a tooth then becomes non-vital, we've maintained the teeth enough to then allow bony healing to take place. So that brought up some confidence that, hey, we might be talking about teeth that are vital today and might become non-vital in the future, but yet we're already in a better place if we've saved the teeth to then establish good bony support for these teeth. And then following all of my pulpal and periapical assessments and radiographic and CT assessments, then we had our interdisciplinary consultations to explore treatment options between Alan and myself. So you can change the slide now, Alan.
Yeah, I just might add one comment is that we're really dealing with an intact blood supply. The periosteum, all of the components of proper healing with good blood supply were intact, which could positively influence the outcome.
Correct. So my initial endodontic clinical findings are listed in this slide, where we found tooth number 6, although it had an apical third root fracture in the apical few millimeters of the root, the pulp was still vital. And we'll talk a little bit more about what that means in future slides here. So we'll just talk about our findings in this slide here. Tooth number 7, we found had an uncomplicated crown fracture and the pulp was non-vital. And I don't know if you picked it up in some of the earlier photos that Alan showed. There was also a discoloration to that tooth as well. Teeth numbers 8 and 9 also had small uncomplicated crown fractures, and the pulps were still vital in those teeth. Tooth number 10 had a complicated crown fracture, significant intrusion, and non-vital pulp. Okay, Alan, next slide. And so we established just a brief initial endodontic treatment plan to then move forward into discussing with both Alan and myself where we would go following this treatment plan. But our primary initial treatment plan here was to perform endodontic therapy on teeth numbers 7 and 10. We were going to observe, and this is a very important point, to continue to reevaluate teeth numbers 6, 8, and 9 throughout both my treatment as well as further treatments that would take place in her treatment plan. And we also want to understand and inform of the strong possibility for additional endodontic therapy following a trauma. We keep reinforcing this, and that it's not bad if this does happen, because the benefit of moving forward saving teeth far outweighed the extraction of teeth and losing all of the osseous support for where those teeth were. Okay, Alan? So again, as I've brought up some statements already, we find that post-trauma endodontics does facilitate healing, because most traumatized teeth do survive either with or without requiring endodontic treatment. Just because a tooth needs root canal doesn't mean we're going to lose it. We find that most traumatized teeth can be maintained for many years in patients after trauma. Endodontically treated teeth facilitate maintenance of the ideal osseous and gingival architecture. And I keep going back to the CT with the comminuted fractures in it, where thinking in my mind, if we had extracted the remaining teeth, what would have been the damage to the bone in that situation? So these teeth being saved really facilitate ideal osseous and gingival architectures. Extractions immediately following, Alan, you wanted to, I probably already said it, that's probably why you advanced the slide. Extractions immediately following traumas with comminuted fractures make restoration of original osseous and gingival architectures doubtful. Thank you. You can advance again. So what is our rationale for endodontic treatment? Why are we suggesting endodontics in this patient? Well, we want to allow the pulpal and periapical status of the teeth, as well as the restorative demands, really to dictate the treatment. So we don't look at a tooth and say, it's been through a trauma, let's just perform endodontics, or a non-vital pulp to say whether or not we should perform endodontics. In addition to, sometimes we may periapically see something going on, or we might see resorption occur. So these findings have to dictate what our treatment is on a particular tooth, understanding that ultimately the healthiest environment for a tooth is a vital pulp and a healthy root structure. So we don't want to be too cavalier about assuming a tooth needs endodontic treatment. However, we do want to be guided by our findings to then perform endodontic treatment.
Let me just add something. We're getting a little bit of feedback now. So panelists, if you can either plug in or if you can get your speakers to be to get the volume as low as possible, I think that'll help all of us. Thank you.
Okay, so I'll take my volume down. Okay. Just Lee, let me know if I need to do anything further with feedback. I can plug in my headphones if I need to.
Will do, Scott. Thank you.
Yep. So now, continuing on with my rationale for endodontic treatment, during treatment, endodontic treatment is not simply about performing a root canal. Endodontic treatment is treating the pulp and the health of the pulp, as well as the periapical structures and related to our pulpal findings. So to me, it's important to allow for continual and frequent reevaluation and assessment. Even on the most simple endodontic treatment I perform in my office, we all follow up our cases at 3, 6, 12, and 24 months time. So this was our chance to allow continual reassessment of Amanda's health during both my observations as well as my treatments with her. And if problems arise during the progression of treatment, we are able to account for them and treat them accordingly, because we haven't just performed a root canal and said, well, there's the door, see you later. We're continually reevaluating patients like Amanda. Okay, Alan?
So now we're approximately a month into her treatment, and I wanted to try to stabilize the number 11 site. And my rationale for doing this is I wanted to consider, obviously, preservation of the alveolus, or that which remained. I wanted to use an inductive bone graft material, something that would give me the highest percentage of vital bone possible. So I used a combination of bone morphogenic protein and allograft, and closed the socket area with a socket seal graft, as you see here, with the express purpose of trying to get the complex, the alveolar complex here, the highest cellular content of active bone cells. So this is the radiograph following the application of the BMP sponges and allograft. And moving along, within a week later, we instituted orthodontic therapy to begin the process of erupting number 10. And you can see the 1 week healing pattern here in the number 11 site, and you can see the beginning of neovascularization. A significant amount of angiogenesis often occurs with BMP2. So here we are another week later, and we can see the nice healing in the number 11 spot, and we're beginning to see some eruption, rather rapid eruption, of number 10. And Amanda is doing a lot better. She has a more positive outlook on where we might be headed. The aesthetics are at least reasonably manageable. So we now have an orthodontist involved in the team, which was part of the discussion prior to this. So we have an endodontist involved, and myself kind of guiding the process of an algorithm here of treatment progression. Here we are another month later. We can see that the extrusion of number 10 has moved along, quite nicely. You can see in the view on the right side of your screen, we have the alignment, if you will, of the incisal edges. And we're beginning to think of the restorative aspect here, and getting the axial alignment of the teeth established so that we can get the best emergence contours possible for possible future restoration should they become part of her treatment. And so with this in mind, I'll turn this portion over to Scott to just highlight the ongoing observations that are occurring between the orthodontist, myself, and the endodontist, which is Scott.
Yeah, so what we see in this series of x-rays, we're just pointing out that we're seeing some more establishment of the bony healing that's taking place. And actually, this panel of x-rays is ahead of what will be coming in the next slides. Don't change yet, Alan. But what I do want to point out is if we see tooth number 6, for example, where you can see the apical segment of that small portion of root, we're starting to see the root actually now line up, whereas in earlier views, tooth number 6 was not in line with that apical segment. So, as Alan pointed out, the orthodontics is really bringing the teeth back to the positions where they should be located. What we see on tooth number 7 is actually calcium hydroxide that's in the root canal that you'll understand that you'll see in the next panel. So we can now switch to that slide, Alan. So we actually saw Amanda here to initiate endodontic treatment on tooth number 7. All of our work is done through a surgical operating microscope, so every aspect of every procedure is photographed, so it's easy for us to show step-by-step the procedure. And so you can see in the far left the x-ray before we started, and then the photos of the tooth before we did our access, which is in the center part of this panel. You can see the calcium hydroxide in the x-ray that's in the center. And then after letting the calcium hydroxide sit in the canal for a minimum of 3 weeks, we then came back and obturated the canal and then restored the endodontic access. And the far left is the final endodontic result. At this point also, both preoperatively before beginning endodontic treatment on number 7, as well as postoperatively, we continued to pulp test teeth number 6 8, 9. 10 was already determined to be non-vital. So in our minds, we thought, okay, now we still have 3 vital teeth, and following the completion of tooth number 7, the next on the endodontic agenda would be to perform endodontic treatment on tooth number 10. You can advance now.
So here we are a month later, just showing the progress. You already understand that there's been some initiation of endodontic therapy and completion on number 7. So this is just showing you the eruptive process of tooth number 10 at this particular point.
So now that we got number 10 into a position that we felt was favorable, where we could actually perform endodontics on it, you can see in this panel here, there's a lot going on in this slide. So let me take you through it. So Alan, if you could point first just to the X-ray in the far left. So at this point, we're assuming we're just performing endodontic treatment on tooth number 10. And once again, pulp testing teeth numbers 8, 9, and 6. And so you can see the photos right next to that far left X-ray of both the preoperative. Before we performed our endodontic access on tooth number 10, you could see there was actually a pulp exposure, which was why the tooth was non-vital. And then you can see our access. So we had Amanda back to our office to do a calcium hydroxide check after we had initiated endodontic treatment on tooth number 10, which brought us to the X-ray that you see in this panel. It's in the middle of the panel. Yep. And Alan, if you could point out the resorption. When we were doing our calcium hydroxide check on tooth number 10, we saw a dramatic difference on teeth numbers 8 and 9 from when we began the endodontic treatment on tooth number 10 to when we just had her back several weeks later to check. So this was a shocking finding for us as well as Amanda. And Amanda's first question was, am I going to lose these teeth? Should I just extract these teeth? And I got on the phone and talked to Alan, and we all agreed that resorption can be halted. Teeth with resorption can be maintained and held in place for many years, and still the bony healing benefit far outweighs removing teeth at this point. So although we had pulpal status, which said these pulps were vital, teeth 8 and 9 were vital, as soon as we saw the resorption, we said now is the time where we need to change the pulpal and periapical health of this tooth by taking out the pulps and putting calcium hydroxide inside these canals. Amanda was on board with continuing to try to save these teeth. So we knew that although we were going to be removing vital pulps, calcium hydroxide does change the actual alkaline environment of the root surface on the external aspect of the tooth, and does show a benefit in halting external root resorption. So at this point then, we opened up, we accessed teeth numbers 8 and 9, and you can see in the middle of the slide where you see the photos, now we have tooth number 10, we reopened tooth number 10, we accessed teeth numbers 8 and 9, and we placed calcium hydroxide in all 3. And I believe, Alan, you were going to advance to the next slide, which shows the calcium hydroxide in all 3. And now if we take a look at where the resorptive defects are in the external root surface of particularly tooth number 9 shows it pretty dramatically there. Tooth number 8 a little bit, but 9 exactly where Alan is pointing to on tooth number 9. As well as if you move over to the X-ray to your right of this, Alan, again, number 9, that's correct. So we see some pretty extensive resorptive defects there, as well as bone loss there. So we're seeing radiolucencies there where we would really like to see bone actually healing in or growing into those areas. But we felt that with having calcium hydroxide in the canal systems, that could promote some bony healing. So now, Alan, if you can back up to the prior slide, please. And now if you take a look, we had Amanda back, and we felt if you take a look at the final X-ray, the areas where we did have loss of bone, we now had bone growing into these areas of resorption. So this says to us we were able to halt the resorptive defects, and the roots may not look pretty, but at least we don't have any active resorption taking place at this point. So we felt these were still good teeth to hold on to to promote further bony healing in this area. Okay, you can change slides. And so we've reviewed this. Yep.
So at this particular point, the purpose for putting this slide in is to identify the healing in the number 11 spot and showing the progress or the identification of which teeth are progressing with endodontic therapy, which is 8, 9, and 10.
Mm-hmm.
I don't know if you want to make any comments at this point, Scott, beyond what I've said.
Well, Amanda was also noticing that her symptoms were improved at this point, and as well as now that she was pretty much symptom-free, she was starting to ask questions about cosmetics, which were pretty apparent in this slide, which I think will bring us to Brian in short order here. So we can advance now. So following all of our extrusion, then we had tooth number 10, root canal was initiated, and this is just restating what we showed you in that prior panel. We initiated root canal in tooth number 10. Then prior to completion of root canal number 10, we reevaluated teeth numbers 8 and 9. Found them to remain vital, but were undergoing external root resorption, which is where we stepped in and performed endodontic treatment on those teeth. You can advance. And endodontic therapy was initiated for teeth numbers 8 and 9 prior to completion of the root canal on tooth number 10, also with calcium hydroxide intracanal medication following a 2-visit model. We continued to reevaluate tooth number 6 throughout, and it continued to remain vital.
So I might add the fact that we went through this co-discovery process and the risks associated with future treatment, the uncertainty of future treatment, it was comfortable to report to Amanda as these changes occurred, and she never looked at these changes as setbacks. She really looked at it as opportunities for us to reassess progress, institute appropriate modified treatment to help her. And all of this ongoing discussion with Amanda is really predicated on the fact that we took a lot of time to establish the relationship and her understanding of what the problems were, and she began to assume responsibility for her problems, understanding that the team was doing the best they could to manage these issues. So we're now up into May, so we're looking at about 7 months of treatment. And at this particular point, Amanda is still continuing to be disappointed by the aesthetics. And so we encouraged her dentist to proceed with perhaps provisionalization because we didn't want to in any way jeopardize these teeth in terms of fractures, and we wanted to stabilize the position of these teeth orthodontically.
This panel of x-rays really shows the calcium hydroxide in the 3 teeth taking place and just showing where things were at in May. And this goes along hand in hand with the prior panels showing the clinical photos and the treatment progress where we actually see the halting of the resorption on tooth number 9 pretty beginning in this slide. And this is prior to our completion.
Now, we seem pretty calm, cool, and collected while we're doing this presentation, but I have to tell you that this was emotionally debilitating for Scott and myself because we really didn't know where we're headed, and there was a big emotional investment in this patient, and there was a real compassionate feeling of not wanting to disappoint her and really hoping to get to the outcome. So it's not all about Amanda. The providers here, the people who are caring for her, are also emotionally invested as well. So this is now Amanda presenting to me after she has a heat process provisional restoration placed by the dentist with whom I have no prior relationship. Now, the significance of these slides are the absence of addressing the number 11 spot as part of this provisional because these teeth are all joined. And this now is giving me a couple issues to deal with. Number one, Amanda is extremely displeased that with all the effort that she's put forth, that she was really very upset about how her teeth looked. And we were back now to crying and emotional mode, which was okay. And it was simply a matter of handing her a box of Kleenex and just letting her talk and express what's going on. But this also raises a point that Lee often raises when it comes to managing people. When certain treaters are confronted with situations where you know that we're never going to get to the outcome that we want. We're never going to get to the point of making the patient happy, because sometimes doctors have certain limitations as to what they feel they can achieve for their patients. At this particular point, Amanda made this somewhat easy. She said, is there anybody that you know that can make my teeth look nicer? And I said, well, I believe I can help you in that regard, but I want you to understand that ethically and professionally, I don't want to remove you from the care of your current dentist, but if you want to go a different route and try to improve the appearance, I can certainly make a recommendation. And that's what I did. And so this brings us to Dr. Vence's participation in treatment. And I want to call your attention to some very important aspects, and I'll kind of comment after Brian makes his comments. So here we are now at 8 months. The patient has been extremely compliant. She's been a really great patient, and this provisional restoration was an emotional setback. I took these radiographs, and not being a restorative doctor, I was still pretty convinced that the intimacy of fit and embrasures and the ability to get the tissue to respond the way we wanted was not going to occur with this provisional restoration. And the dentist had already explained that this was a laboratory process provisional restoration, and this was the best that could be done. And that just about threw Amanda over a cliff, because this is not what she was imagining her future to be like. So I referred her to Brian, and I'll let Brian talk a little bit about what he did when he saw her in July.
Alan, let me just ask you a question first, because now you reached a critical stage where you mentioned that, in fact, she has to switch dentists. And of course, she's requesting it of you, so ethically you're okay. Was there any contact you had with the original restorative dentist before you referred to Brian?
I did have contact with her. I made a call. I also documented photographically, radiographically, and in a letter what some of the shortcomings were. And I didn't know whether or not we were going to get to the end result that we wanted. And that Amanda had requested a referral to a different restorative doctor. And this particular dentist was not at all displeased with the fact that Amanda would see somebody else. I think they'd kind of emotionally run their course, and maybe the responsibilities of getting to the end result and the expectations that Amanda felt were important to her wasn't something that that could be achieved. Part of this also, and I understand a little bit about where we're coming from with this question. Part of it for me was actually easy to want to make the referral. I just needed that little coaxing from Amanda, is that I didn't have an established relationship with this dentist. And that fact alone tend to loosen the noose around my neck, trying to balance both sides of the equation.
Very good, thank you.
So I'll let Brian kind of talk about his first encounter with Amanda.
Complicating the factors of Amanda's healing is the fact that she's a smoker. So that doesn't help with the gingival tissues, nor does it help with making a provisional stand up and look good as far as color, because the provisional material gets discolored. But the most important thing I thought to achieve with Amanda was some kind of relief in the interproximal areas to allow the papillas to come back as much as possible. As you can see, we have a disparity between the papillary tissue between 9 and 10 and what we have on 7 and 8. Obviously we'd ideally like to get all those papillary tips level, if that's possible. But because the orthodontic treatment had to be stopped because the resorption were kind of left with where tooth number 10 ended up being and couldn't be fully extruded to reestablish the proper papillary level there. So what I did is I made a provisional that added tooth number 11 into it as a pontic, and basically created an emergence profile around all these teeth to start grooming the soft tissue.
So Brian, if I remember, because I'm not sure the audience will understand exactly what you just said, he took the existing provisional, groomed it, contoured it, modified it, and added the ponic.
Mm-hmm.
Okay. Now, what I think is most significant about this is that with the same provisional restoration that was made by the other restorative doctor, Brian took the same provisional restoration and changed it into the appearance that you see now. And you can just imagine the level of confidence, and you can feel the relationship improving, because the patient basically walks in with this to Brian's office and leaves with this. And this was a big emotional turnaround, because there's a lot of responsibility in referring Amanda to somebody who's going to improve the aesthetics, but she got an opportunity to see this happen right before her very eyes.
And I believe at that point in time, it was a service I provided to her and didn't charge her for it, because I kind of said, let me see if I can start to make you happy. And if I can, we'll move on to further treatment. So I think I just spent some time reshaping those provisionals and then provisionalizing them again with some temporary cement.
Brian, did you have to reestablish margins there as well? Because it didn't seem like marginal fit was there. What, and if so, what?
I mean,
what
the provisional in those first photographs look like they don't fit intimately because there's some composite that isn't radiopaque. So it's not as bad as it appears. Otherwise, they would just have fallen off if there was that much space. But yes, I went ahead and marginated these provisionals. So what I do is I go ahead and take out the cement, and I basically hollow ground out the provisionals and relined them with some new provisional material. And then I picked up the margins with flowable composite and then finished the margins so that they had an intimate fit.
Thank you.
Marginating provisionals is something that I remember the first time I heard someone tell me about marginating a provisional when I was a younger dentist. It was probably about maybe 25 years ago now. I was probably 8 years out in practice, and I hadn't even heard of the term marginating a provisional. And so it was about, at that point in time, it was flowing acrylic into the marginal areas and let it kind of adapt and fill in any spaces after you have basically relined a shell provisional. And it was a level of refinement that I hadn't been exposed to in dental school or had heard of, except for when I was at the American Academy of Aesthetic Dentistry meeting in a swimming pool speaking with a prosthodontist. And he said, do I marginate provisionals? And I was like, kind of like, it was one of those stunned moments where you're like, I think I'm about to hear something really important. So marginating a provisional is a really important step. It's time consuming, but it allows you to groom the soft tissue architecture, whether it's around implants or natural teeth.
So this cone beam was taken now 7 months after Amanda's initial presentation, and you can begin to see the healing of the comminuted fractures. I mean, it's pretty dramatic. I mean, good news, she's 25, maybe approaching 26 now. But I want to just call your attention to number 7. You may have remembered that comminuted fracture that was still attached to the root. With the repositioning of the teeth, you can see how this facial alveolar bone has really been nicely reestablished. And there's still some ongoing healing that's occurring, but for the most part, this was really a dramatic change in terms of improvement at this particular point.
So here we are. This is a follow-up taken in June, and we've got the complete endodontic treatments. We reevaluated the areas of resorption. We saw bone invaginating into the areas of resorption. We didn't see any more periapical findings on these teeth. and we had no evidence of any comminuted fractures. So we were also, as Alan had pointed out early on, we were starting to breathe a little bit of a sigh of relief that we're going to be able to retain these teeth for a significant portion of time. Also, we don't show it here, but we also continue to reevaluate tooth number 6, which continues to respond vital to our pulp test and had normal periapical appearance. So we were starting to feel like, okay, we can continue on with our restorative treatment plan at this point.
So this is the way that Amanda presented now. This is about 4 months after Brian had seen her. And so these pictures are those which I got from Brian to just kind of demonstrate to me what's happening with the soft tissue. And I'll kind of let Brian discuss what his observations were.
So, it's at this point that you kind of start to see what margining the provisional would do. This is another provisional that was fabricated. And you can, if you look at the previous radiograph, you can see the more intimate fit with a radiopaque material with the provisionals. And this is something that Alan's probably more used to seeing coming from me. And in the next photo, you can see what's going on as far as the papillary development around these teeth, including the caul between the facial and palatal papilla tips. So we want to kind of try to get that nice keratinized tissue 360 degrees around the teeth. And basically, if I was to take that provisional out and make an impression, I could probably get a 360 degree circumferential intracellular impression of those teeth without packing a cord. That's how healthy that tissue has become. So the idea of having to use electrosurge or lasers to stop hemorrhage when you're making impressions is really, to me, basically trying to do too much in one appointment. You need to let the tissue mature, let it fully epithelialize and heal, and then you can get accurate impressions later on down the road to make intimate fitting restorations for your definitive restorations.
I think just to keep everybody appraised of the timeline, we're now approaching 1 year into Amanda's treatment. Remember, we saw her in November of 12. It's now October of 13. So at this particular point, Brian and I felt that we had sufficiently adequate healing in the number 11 spot that we would go ahead and place an implant and make a tooth-supported provisional restoration for number 11. In the view down here, you can see the model that Brian provided, which included the ponic in the number 11 spot, which essentially is giving me my navigated options as to where the final tooth would be and the facial palatal position or the axial inclination of the implant. Another model showing the teeth with the provisional removed. All these models are merged together using Simplant to develop a treatment strategy for guided surgery that we could use for immediate provisionalization.
So at this point in time, I went ahead and had obtained an impression of the implant, and we're going to go ahead and fabricate a provisional restoration and start grooming the soft tissue. So this is the provisional fabricated on the cast.
Yeah, we might just add that the guide that was going to be used at the time of surgery was used to deliver the implant at the proper depth and the proper rotational timing so that the provisional could be made and placed at the time of her surgery.
So if you go ahead and take to Alan's next set of slides.
So this just basically shows you, and I'm not doing this just to present how to do the technique, but the steps that are involved in guided surgery. It basically was a flapless approach. What I think is important to point out is the rich red bony shavings that we're looking at from the osteotomy preparation, which supports the vascularization of the bone in the area of the healing. And we see this throughout the process. So understanding that this implant hopefully will be in this patient's mouth for a long period of time. We want the bone with the best osteogenic, osseointegration potential. And so we're just going through the steps here of what's happening, ultimately leading to the implant being placed, and then doing an ISQ to check the stability of the implant, going ahead and measuring the cellular depth to see how it corresponds with what was on the model. And then this is the provisional that is being replaced along with the provisional on the canine, and I'll let Brian comment on what he did in this particular aspect.
Alan, what's the minimum ISQ that you'll be satisfied with before you'll allow for immediate provisionalization?
Yeah, I'd like to see at least, I'm kind of a conservative person, I'd like to see at least 60 or better. I don't recall what the reading was, but generally speaking, in this situation, after waiting 6-7 months with BMP as my inductive agent, we're probably looking in the 70s, maybe close to to 80.
Thank you.
So that the implant placement was done so it's at least 3 millimeters apical to the free gingival margin that we'd like to attain. And in this particular case, this was fabricated off the cast as provisional. And you'll notice that the contour of this canine isn't similar to the contour of the contralateral canine. So we're going to eventually want to correct that, but at this point in time, we're just going to allow healing of the soft tissue and kind of supporting those interproximal papillas in as far as the aesthetics and healing of that is concerned. So as we move on, you can see how the provisional comes down and fits that temporary cylinder, and you can see the emergence profile coming off the implant. And it's not like an ovate, like a half ovate pontic form, but it kind of comes straight up off the implant, and then it expands out to the emergence profile that we're trying to create. This is just more of the healing, and you can see more of the discoloration of the provisional as time has gone on.
Yeah, I think one of the things to point out, Brian, is we're beginning to see a more positive papilla response between 9 and 10.
Mm-hmm. And that's without moving teeth, just letting it heal. So here's what I kind of wanted to get to. Eventually, we want to try to create a provisional that actually mimics the contralateral canine. So what I did is I took this provisional and I added material by micro-etching the facial of the composite, and then I basically built with composite the shape that I wanted. This is actually a renamel, and overlapped the soft tissue to where I wanted to have that free gingival margin be. And what I'll eventually do is fill in. Those are just some pencil marks showing where I want the line angles and some of the developmental grooves and things. But I'm going to come off that implant head and where the temporary cylinder is, and I'm going to develop that composite so it comes to where I want the free gingival margin, and it's going to push on that facial soft tissue. And so that's what I ended up doing and polishing it. And so we'll see how that looks in the mouth. So this is one picture beforehand, and now I think the next one will show it blanching. And so there it is, a more similar contour to the contralateral canine, and pushing that free gingival margin more apically, and also pushing the soft tissue facially. And so when you're placing implants, you know, one of the things that has to happen is the surgeon has to think like a restorative doctor or prosthetist, and the prosthetist or restorative doctor has to think like an implant surgeon. So we know that the surgeon would like to place that implant more palatally, so that we have 2 millimeters of bone facially to the implant. Natural teeth don't have 2 millimeters of bone. On average, they have sometimes less than 0.5 millimeter of bone. And so the root form, the cross-sectional root form, as it comes through the soft tissue on a canine, is kind of an ovoid form, and you have a cylindrical shaped implant. So that shape has to be created in your provisional restoration with your emergence profile, but it has to come off that cylindrical shaped implant. And so it's going to extend quite a bit facially as it pushes that soft tissue. But that's the kind of the art of all this, the grooming of the soft tissue. And it's really kind of one of the more satisfying things for me is to play with biologic width, whether it's around implants or natural teeth, to groom soft tissue to give the appearance of nature.
Alan, could you do me a favor? Go back one slide, and I just want to bring out a point. Let's see the provisional that Brian made on the canine on number 11. So maybe 2 slides. Yeah, and I want you to take a look at this because this is important when we're trying to groom tissue, as Brian's talking about. Notice the S-shaped curve or the concavity that's developed from what is the potentially the CEJ down to the implant. You know, we often have a tendency to do to create a convexity rather than a concavity, and that will displace tissue. But by doing what Brian did here, it encourages more tissue growth and more tissue bulk in order to help restore the gingival tissue. We can do all we want with a soft tissue graft, but unless we have this particular shape, we're going to stretch the tissue, we're going to limit the amount of tissue bulk and actually limit the blood supply to that area. This is an important concept when we're developing our provisionals.
So now we're starting to get some balance between the 2 canines. Still not perfect yet, but it's going to be something that my technician can take to another level. And, you know, basically what I'm trying to do is I'm trying to create the space and allow my technologist to fill the space. And I kind of look at myself as the gross focus, like if you were focusing on a microscope, you know, the coarse focus, and then the fine focus is really my technologist. So I'm starting to give him some space appropriation to make the definitive restorations. One of the important things when we're fabricating restorations is we need to know what the preparation shade is. So here I've taken a Denton shade A2 from the Ivoclar shade guide and given him something that he can then try to see what he's trying to mask. We also want to have shade tabs of the various restorations and comparing them to the lower arch. I'm taking several different types of shades here. I'm taking the A ranges and the B ranges. I know a lot of people like to write a novel on the shades and what they're seeing to the ceramist, but I think it's a lot easier to photograph 3 different shade tabs. We use the highest value shade tab in the center, A1, and then the more chromatic shades to the sides. And with this, the technologist can look at different aspects of the tooth and decide, you know, what shade is he going to make in the cervical area, what's he going to do in the mid third of the tooth, and then what is he going to do as far as the incisal effects. And so this gives him freedom to kind of camouflage the teeth and blend them in a little bit better. You know, centrals don't have the same shade as laterals or as canines because of how the structure is made in nature. Canines have a lot more dentin behind them. So if you think of teeth as filters, you know, canines have more yellow filters for the light to go through than a lateral. And a central has not as much, as many filters for the light to go through as a canine, but more than a lateral, and it affects the value and the chroma saturation and the hue of the tooth as the technologist bakes his ceramics to mimic nature. Next. So here we are. I think we're still in the provisionalization stage, if I'm not mistaken. And we've got some restorations that seem to fit pretty good there. We've got, you know, intimate margins, and we have the emergence profile developed off the canine. And we also have healing of the bone, like Scott was talking about. You can see the areas that were, you know, so moth-eaten along the sides of these root surfaces are now replaced with bone. And so a lot of times people will say to me, well, you know, you've got root resorption, and they're like, panic, you know. Well, to me, root resorption is just a slow replacement of the dentin with bone. So it's basically a bone grafting procedure. And so it's not a problem. It's something that sets up the implant site if the tooth has to come out. we may end up losing tooth number 10 because I think maybe some resorption has reoccurred, and we'll talk about that at the end. But even if we lose 10, it's even a tooth we could root bank, save, and utilize it with a cantilever off of number 11 and really not have put her through a whole lot more treatment. So saving teeth is a very important aspect for me, because teeth have, some things that implants don't. One of them is the scallop nature interproximally. They also have periodontal ligament fibers, periodontal ligaments with Sharpie fibers inserting into the cementum that makes them more resistant to periodontal breakdown when they're treated properly. And like cementum almost has a magical quality about it. I mean, I think you can take cementum and transplant it into a cheek and it will grow bone. So those are some things that teeth can do that implants definitely can't. Once you remove the tooth, it's gone. Once you remove an implant, another implant could go in there.
So at this point, just so everybody understands the timeline, we're about 26 months now into treatment, working to improve the integrity of the provisionals, the soft tissue grooming. Amanda is now in a delightful frame of mind, and the whole nature of this process is really emotionally changed for everybody that's involved.
I believe we made the final provisionals at this point where they were actually separate, okay? So these provisionals were fabricated by my technologist, Don Cornell, did this case. Another technologist I work with is a fine technologist, is Tadanori Taniguchi. But Don was using some CAD/CAM provisionals, and these are nice because you can, we can make them as splinted provisional, and then we can switch out and mill them out as single unit provisionals and maintain the shape. And then once we have the shape exactly the way we want it, we can go ahead then and mill that out in zirconia. We can mill it out in wax and press it in Emax. There's a lot of different ways that these restorations can be fabricated. But CAD/CAM restorations, it's not so much the definitive restoration that the CAD/CAM is important for me. It's the fabricating of the provisionals and being able to replicate the form without having to be such a laborious procedure. We can just tweak things a little bit, change them, and then mill it out in something to get the patient's satisfaction. And if you look at this, I mean, while the gingival contours aren't absolutely ideal, I think the provisionals now are starting to even groom the soft tissue further. She's able to floss interproximally, and I think the papillary levels are actually improving quite acceptably between 9 and 10, for example. So here's the 4 natural tooth preparations on 7, 8, and 9, 7, 8, 9, and 10. And then tooth number 11 has a zirconia abutment. It's a custom abutment. And you can see that the margin has been made right to the level of the soft tissue. This is going to happen to be a cement retained restoration that's going to go in there, but it's not going to be a problem as far as cement getting subgingival because the margin's not subgingival. And so here are the definitive restorations in place, and you can see they look quite a bit like the provisionals. This is actually, I think, right at the time of placement. And then here's after things had matured. So we went from fractured natural teeth, quite a hopeless situation, and I could see why someone might think we have to remove these teeth and put implants in there, as though implants are going to be a definitive solution. But as Scott had pointed out, with the alveolar fractures and potential for bone being removed with the extractions of the implants and the loss of the soft tissue architectural housing, getting back to ideal aesthetics would be a real challenge with implants. And who's to say implants are going to hold up the course of someone's full life without peri-implantitis? So these are the definitive restorations after we had some maturation of the soft tissue, and you can see some of those little black triangles that you'd saw when the restorations were placed have gone away as the soft tissue has relaxed and adapted into those interproximal embrasures and contours. We obviously have some long contact zones there that we've created in the restorations to help eliminate those black triangles. But certainly after 6 weeks post-cementation, I think we have a beautiful young lady that's restored her sense of self through the dental restorations that was robbed from her through the accident.
Well, life doesn't always move in ways we would like it to. So in our ongoing evaluations of Amanda, we determined that there was a problem on the apical portion of number 10, which was potentially putting the implant at risk. It was my responsibility to report to Amanda that there was a problem. It was emotionally challenging to now talk about a setback. However, I reassured Amanda, and incidentally, she thought that the setback was somehow causing these restorations to have to be redone, but we told her that we could actually solve this problem, which is at the end of the tooth, by a small surgical procedure, which then was followed by me handing her a half a box of Kleenex. And that's I'm saying that compared to the full box of Kleenex that we were handing her in the beginning of treatment. Well, as you recall, Amanda really at this particular aspect of treatment is not being anesthetized to do provisional grooming and modifications, but this is a surgical procedure. And the dilemma that we were faced with is that Scott was going to perform the procedure. He does everything under the microscope, which is terrific, but she's going to require sedation. And I wasn't prepared to provide sedation in an environment that didn't support emergency management of a sedated patient. So Scott was kind enough to come to my office to perform the procedure and bring a portable microscope to my office. So I ended up being the anesthesiologist for Scott. And it was actually a terrific learning experience for me because I got a chance to watch an incredibly skillful microsurgeon with incredibly proper orthopedic posture and everything that for my entire career was not a hallmark of my orthopedic prowess. But I got a chance to watch Scott perform what I thought was incredibly delicate, complicated surgery, which was really a finesse. So I got a chance to have free CE by me providing the sedation for for Amanda. So I don't know if you want to add some thoughts, Scott, or should we go on to the next slide?
Well, I think we lost the slide with me actually carrying the microscope on my shoulder, walking in the front door of your office, so then we could set it up in your office. So.
Well, actually, I intentionally did not take a picture of you bringing the microscope because we didn't want to use any of our workman's comp, from our office policy.
Right. I understand that. But it was also a learning experience for myself to watch you manage Amanda with your anesthesia, because I've worked with many anesthesiologists where patients were completely out cold and sedated. And we were able to have a lovely conversation. Amanda was still conscious, but feeling no pain and in very good spirits, and go through and perform the procedure. And as you had pointed out, from your discovery to then my showing up in your office was a very short period of time. And if we can move to the next panel. So these are actually slides that were x-rays that were taken in your office. And so they're actually, I think, flipped, where the first one was showing do you want to back up? Yep. So the one on the right was showing prior to our actually entering and doing any surgical performance. And then the one on the left was post-surgical. But she actually came to my office prior to the surgical process, if you want to go to the next slide, where this was our x-ray, and we actually could clearly demonstrate that there was a periapical finding at the apex of tooth number 10. But we still felt that the benefit of retaining the tooth and the bony architecture far outweighed this sort of small setback that we ran into. We also noted that the resorptive defects on teeth numbers 9 and 8 hadn't really progressed, so we felt pretty good about that as well. Now, if you move to the next slide, we can see some of the bony healing that had taken place on all the different teeth throughout this time. You can see the view on number 6 with the apical few millimeters still separate from the structure of that root, and that tooth still maintained its vitality. We continue to get both buccal and palatal cortical plate growth, and so there's no sign of any bony fractures at this point. This also shows this is a Panorex view of the actual periapical lesion at the apex of tooth number 10. And then here we show from really the far left, the preoperative x-ray prior to performing the apicectomy procedure. We were working in Alan's office, so I didn't have the ability to take photographs, so all I have is radiographs to show you from the surgical procedure. But you can see in the third x-ray, really, that's the immediate post-operative radiograph taken in Alan's office. And then to the right of that, the 6-month follow-up x-ray showing some bony healing taking place. Then the 12-month post-operative radiograph showing really complete bony healing at the apex, so reestablishment of the dental alveolar apparatus there. You can even see the PDL continuous around the apex of the tooth. So we felt like surgically, this was a step in the right direction.
Scott, maybe I missed it, but what was the surgical finding at the apex? What did you see?
At the apex was just a traditional appearance of the radiographic apex, and then we didn't have an actual amount of tissue to send out to a biopsy. Is that correct, Alan? If I remember that we just had, it was pus that we just opened up into this window filled with pus, so there wasn't anything that we sent out to get a biopsy for. But something also that was, Alan helped in facilitate healing is, I believe you did some, you made a BMP tissue segment that was placed in surgically, is that correct?
You know, quite honestly, I don't recall. I'd have to go back and check my my records.
Yeah, you did. You actually were able to help before. I remember before I went to suture the flap back into position, you said, "Hold on," and you walked into the room with this magic material that the aura was coming out of that you wanted to place into the periapical crypt, which certainly did facilitate tremendous healing.
So recently she was in for just a routine hygiene visit, and this is how things appear at this point in time. You can see it still has nice soft tissue architecture. It does seem like there's been a change in relationship between the canine, the centrals, and the lateral. Like she may have had maybe some growth, facial growth. I'm not sure. She was, I think is she 31 now at this point in time? And she was like maybe 26, 24 back then. So, you know, there may have been some growth or there may have been some supereruption. I don't know, but it seems like there's been a slight change to the gingival levels between the anterior teeth and the implant restoration. However, you know, the aesthetics are still holding up, and I think she's in a much better place than if she would have gone with implants at this point in time. We do, in the radiographs, see some resorption of tooth number 10.
Yeah, so these are the radiographs that recently were taken at Brian's office. And then, Alan, if you could focus in on there we go. So if you can see on the mesial cervical area on tooth number 10, we do feel that there has been some progression of the resorption on tooth number 10, which makes us pause and then start focusing and discussing future options with number 10, both restoratively and possibly root banking this route, just for some ideas of where to go from here. Nothing that needs to be decided upon immediately. There's no periapical pathology occurring, but we do want to start to set the stage for whether this maintains itself or if this progresses.
Yeah, Brian had mentioned to me, because I asked him what he saw clinically at the time that he visited with Amanda, and he told me that probe depths were normal and that the soft tissue response on the palate and other areas were normal. So at this point, this is just it's something in progress, and we'll just need to continue to, to monitor this.
But she
Is
asked
there
me
consideration to using trichloroacetic acid or something going in there surgically in order to be able to rescue it, or you feel with all the damage that's occurring here that it's just number
Well,
one, compromise the aesthetics, but number two, do you think it could even work?
Well, certainly to restore the resorptive defect, absolutely. If we were to do an external resorptive repair, we would use TCA first and then restore that defect. But I would need to talk to Alan and Brian about what would we be doing to the actual architecture of the area to try to restore that. Who knows what the soft tissue will end up looking like if we go in there and try to restore that proximal defect that's there.
Well, it should be noted that it was a tangential fracture, and because of some of the problems that we had, we never deliberately attempted to do crown lengthening on the palatal aspect. And Brian finished the margin as a finish line to the available tooth structure. So I think before we would do anything, we would have to determine the location of this lesion. I think if the lesion were more to the facial, it would give me greater pause to not want to disrupt the aesthetics. If it was towards the palate, we probably could manage that. But I think at this particular point, this may not have been something that was thoroughly discussed with Amanda within the past month or so. So this is probably a good opportunity to set the stage, as you said, Scott, to talk about the need to monitor this more closely, which also adds incentive to her responsibility to continue regular recare and maintenance visits in Brian's office, to facilitate continued observation and monitoring.
I did discuss this with her, and she, kind of like, well, what does this all mean? And I said, ultimately, like worst case scenario, you could root bank the tooth and do a 2-unit cantilever off the existing implant in tooth number 11 site. So I don't think it's a huge setback for her as far as emotionally and everything. And she does know there's resorption there. So she was concerned of whether it would need another implant there. And I said it's an option, but I don't really see it as, as good of an option as root banking the tooth and just doing a 2-unit cantilever off of tooth number 11 if you want to try to maintain papillary heights.
And also, if you cantilever off of 11, that would give you the option to then make the crown on 11 look a little longer too, to get a better approximation of the incisal edges with the anterior teeth that have continued to grow.
Mm-hmm.
Yeah, I think if we look at the work of Garber and the Salamas and Dennis Tarnow, we know that as long as we have the teeth, we can maintain interproximal bone heights. And whatever the succession of tooth loss that might be in the future, hopefully this will work out so that we'll never have a situation where we have 2 implants next to one another, which I think would be very difficult to manage. So just in summary, I just want to let Scott and Brian know how much of a pleasure it was to work with people who could manage their area of expertise and responsibility to the level that they did. I think the fact that all of us, have had professional relationships ongoing for quite a long time, made it seem, at least to Amanda, that didn't matter what office she was in, she was being treated by the same team of players. And I think Amanda also came to understand that we were all supporting one another. We were all accountable at the same level. And each of us, had a fundamental stake and responsibility in her long-term, care. So the idea of the co-discovery and really taking a patient who knew nothing about what dentistry could offer, a plane ride that ended with not knowing whether or not she would accept treatment, having the ethical presence to withdraw from treatment if the patient was going to embark upon a strategy that she was driving rather than the team was driving. All of those things made for an interesting treatment adventure, so to speak, and I think it still is an adventure. But I think the bottom line is that there are many options that might be potentially available in the future that we don't know about. There may be restorative options and biologic breakthroughs that we don't know about at this particular point. But I think when all is said and done, this is the simplest, most conservative, most respectful treatment that we could provide. And still, we don't know exactly what the future holds. I don't know if Scott or Brian, if you want to add any concluding thoughts.
Yep. Brian, go ahead.
Well, certainly the option of placing implants is still an available option, right? So we haven't lost anything from that option if it was done to begin with, but we certainly would have, I think, lost a lot of the aesthetics and just psychologically, the idea of losing your teeth at such a young age, I think would have been more traumatic than what she went through. So I think that the idea of saving teeth and giving yourself options for the future is a really nice service for patients.
Yeah. And I really applaud the clinicians I'm glad that I had the opportunity to work with, because every time I see this presentation, I gasp at some of the fantastic work that I see here. But I also go back to the fact that Amanda is in so much of a better position today because we went through this, and now she has fantastic bone, fantastic structures to work with, both osseous and gingival to move forward with, as opposed to, like Brian said, certainly implants to extract all these teeth at the beginning and place implants could have been done, but we would have been in a pretty fearful position, especially if skeletal growth was continuing, which obviously you can see in the presentation there was some continued growth. We wouldn't have seen any growth take place with these implants. So she would have been already in a worse position. So she's in a much better position today and has a lot of options to move forward with.
I think if we look at this, for all of us looking at this, there is a healing power to the periodontal ligament. Yes, it's very easy to extract, and the doctors talked about the alveolar changes that would occur if the teeth were extracted, particularly extracting at a time when there were already alveolar fractures. Can you imagine what could have occurred? Yet it was really the periodontal ligament and the cementum that was holding this whole thing together. And so what these doctors have done is essentially have harnessed that power in order to be able to create what is I'm not using hyperbole here, that essentially you were able to save her alveolus, save her aesthetics, and really give her a totally different life just by doing it this way, by monitoring, looking, allowing the body to heal, and to allow to create this kind of an aesthetic result. Let me ask a couple questions. There are a couple questions that are here. One is, was she wearing an appliance, some kind of a night guard post-treatment?
She had one. I don't know if she was wearing it.
Okay, good. The second question is one of fee development. When you're so unsure as to what you're going to do and when you're going to do it, how do you tell the patient? Or what do you do?
Yeah, let me take that question first, because I was the one who probably had the easiest discussion in terms of fees. Really, my role for the most part was to facilitate getting Amanda in the proper hands at the proper time. So my involvement was really the alveolar bone graft as well as implant placement. So that's pretty straightforward and simple. I think the more complicated aspect of the question should be turned over to Scott and Brian, simply because I think that's what the question begs an answer for.
Sure. Well, I also felt I had a pretty easy position because we were talking about partial root canal treatment until seeing successful healing. So in my office, we certainly don't charge. We charge for a consultation, and then we don't charge for a completed root canal until we complete a root canal. And if we can't complete a root canal, we don't ever charge even a full fee or even half the fee. So we just have a partial fee. So she knew up front that if we were able to complete a root canal treatment, then we would charge the full root canal treatment fee. And if we were just talking about a partial root canal or maybe partial root canal plus a calcium hydroxide change or two, we were able to spell it out for her exactly what the fees would be. So there would be no mystery in my office. Nor was there any overcharging in my office if we didn't see success of a treatment. But I now defer to Brian to talk about his fee schedule.
Right. So I think that probably, as is typically the case in our office, we're the quarterback of the treatment, and we're basically like in kind of like a general contractor who might also be the carpenter who's hiring out for the electrician, the plumbing, the different things. So we are working with specialists, to obviously collaborate with and develop an action plan for the patient. But I usually am developing what the action plan is out of a process of co-discovery. And the process of co-discovery is something that would probably make a really good webinar to do with my treatment coordinator someday, because it's quite a fascinating thing, and it's developed over the years for me, because I've been doing this 33 years, being a dentist. And I learned really early on that you don't get to do the what's possible in dentistry based on insurance companies. You get to do what's probable in dentistry based on insurance company. What's average, what's mediocre, what's usual, customary, and reasonable. But you can't take and integrate and get synergy out of something that really, when you think about it, this woman probably saved a lot of money by doing this treatment this way, as opposed to other options and what it may entail further on down the road. So co-discovery allows us to work with patients to help them identify what their problems are aesthetically, functionally, structurally, biologically, what their preferences are. And our goal is to do the least amount of restorative dentistry possible to meet the aesthetic and functional needs of the patient, restore the structure and integrity of the teeth, to preserve the biologic health. So as Alan would say, they may have sustainable oral health for a lifetime. And so co-discovery allows that. Patients, I believe, understand that want to take responsibility. And so they co-write the action plan and the phases. And so we lay out the phases step by step, and I get paid for my time, essentially, when I'm making provisionals, remaking provisionals, grooming soft tissue, and then getting to the definitive restorations, seeing the restorations. There's all fees established with that. And patients, for the most part, understand that because they realize that, we need to get paid for the time we spend helping them.
Very good. Brian, there is a question for you, and that question is, how did you attach the Pontic number 11 to the existing provisional?
Oh, yeah. Well, I put a piece of orthodontic wire in there and then used acrylic. But eventually we used a CAD-CAM shell, actually a CAD-CAM provisional that had it attached until something could be fabricated like what Alan finally placed the implant, when we could finally place an implant-supported provisional. So at first it was kind of like just crossing our fingers. I didn't know. I told her, I don't know if this will just break off or not. I want you to see what it can look like eventually. And it remarkably stayed in place until Alan got to place the implant.
Very good.
I took it out of occlusion, obviously.
Sure, sure.
Mm-hmm.
Well, doctors, this was an outstanding presentation. Certainly, you gave this patient a tremendous service and testimony to your skill and to your patients to be able to provide such a fabulous restorative result. This woman was very fortunate to have the three of you working with her.
One thing I might want to add, there's a fourth provider here that is the technologist, Don Cornell, that is a master ceramist and also understands the biology of the form and contour that happens apical to the free gingival margin and papillary tips in order to pull all this off. So, you know, it's one thing to think it and say it as a dentist. It's another thing to make it happen with your fingers and hands to actually fabricate restorations that do, you know, support the biology and represent nature.
Absolutely right. Dr. Brian Bensay, Dr. Scott Benkover, Dr. Alan Rosenfeld, thanks for preparing this excellent presentation. And thank all of you for joining us tonight. It was a great webinar, and please join us again for our next one, which will be in January, and you get publicity about that. Thanks for joining us. Good night.
All right, good night.
Thank you very much. Good night.